Yeah, hi everybody. This is the review recording for the final exam. I mean, some of the stuff we've gone over, some of the stuff we haven't gone over completely because we still have a little more time left. This is Thursday, 23rd. So I'm going to start to cover. There's really four major areas that are on the exam. I'm just putting up in the usual way. I'm just going to look at the exam and start to talk about it. And I don't know if it's necessarily all in order, but digestive, urinary, male and female reproductive. A side note for those, because we didn't have a lot of people in class yesterday, about half the class. There's some review the anatomy for male and female, which is more, it's relevant in the context of looking at the physiology. So I'm going to have some basic anatomy questions I would think that would be on there, and very possibly ones that you saw before. So I hope when we had for the advanced anatomy. So let's get going with this. We start with digestive. So it's really important to understand where things are digested and absorbed. So it's all about when the enzymes are. Remember, in the mouth, we start with amylases in the mouth. We start with starches. After that, we don't touch starches until they get into the small intestine, and then you get the pancreatic amylase, and then it begins to break down starches. Eventually, the final step, as you're breaking down glycogen and you're breaking down any of the other ingested starches or sugars, is you have to get to the point where they are effectively in disaccharides, depending what they are. When they get to disaccharides, the problem is we can't absorb them. You have to be a monosaccharide. So the brush border enzymes are where we see the things like maltase, lactase, okay, sucrase, that allow you to break it down into the simple sugar, the monosaccharides, right? They're all simple sugars, glucose, galactose, and fructose. And so that's really you have to be very familiar with that pathway as well. What goes on, and then that's really what lactose intolerance is all about. Lactose intolerance is you don't make the lactase at those brush border enzymes, and it becomes, not only does it's not absorbed and it drags water along, but interestingly, it acts as an irritant if it's not absorbed. And people are very, very sensitive. I think we all know people who are lactose intolerant. So I think that's part of the thing that you have to be able to take a look at. The large intestine's a little more simple. Okay, let me get back to the enzymes. I was thinking about fats. We start in the mouth, lingual lipase. Okay, you have gastric lipase, and then again, once it gets into the small intestine, that's where you're going to start to see additional enzymes. We don't really have to. They're all variations of lipases and facilitate uh, the breakdown of the fats into the long chain fatty acids, probably recycling a lot of the glycerol into a variety of other metabolic pathways that you learn about in cell and mollac and different areas. And then what will happen is that those long chain fatty acids, that's the beta oxidation that I'm sure you're all familiar with. I'm not going to ask about that because, again, that's more, to me, that's more cell and mollac than it is physiology. I'm trying to give you the basics about that. So we cover starches. Now, proteins, really, the only time we get any handle on proteins is with pepsin. So pepsinogen being activated with the hydrochloric acid by the pepsin that occurs in the stomach. After that, then it's relying on all those zymogens, all those enzymes that are, the vast majority of those are, other than the amylase, are proteolytic enzymes that become activated, pH activated at the appropriate alkaline pH, and then and effectively that's when we break them down. And remember, it's the same thing with the brush border. We have to take those, we break them down from, by the time they get to dipeptides, which you can't absorb, they're too large, they have to be single amino acids, and that's what's absorbed. In a large intestine, not a whole lot. Some B vitamins are there, maybe some vitamin K, water. That's really what's absorbed there. And it's not that we can't supplement for those. If there's problems with the colon, again, the colon is non essential. Pardon me. Early in the morning, trying to talk. And as well as water and electrolytes are balanced out. Again, being non essential, the small intestine can compensate for those. And we have relatively easy ways to compensate otherwise from regard to that. When we stimulate the pancreas, beg your pardon, we stimulate when food passes into the from the stomach into the small intestine, the mechanical receptors, the pH receptors, the osmolarity receptors, all trigger the release of two major chemicals that act as really the provoking agents, the hormones that make the whole system work. They're cholecystokinin, which goes to the liver and facilitates the release of bile and bile salts and enables fat digestion, and secretin, which is the triggering hormone for all of the pancreas. They're vital to understand. And so they really do a lot of those activities. In the meantime, they make sure that the sphincter is able to allow the passage of food as they begin to be produced at all of those areas. So if anything, they and now by with foods entering the stomach so simultaneously, they actually relax the gastroesophageal sphincter. It's very interesting how it all works. The coordination of digestion as soon food starts to pass in your stomach, a lot of people feel the urge to go to the bathroom. That's called the gastrocolic reflex. It's almost like sending a message. Okay, things are moving. Okay, stuff's going in the stomach. You may want to clear out. I mean, I don't mean to be overly graphic, but to me, it simplifies the idea message. It's food's going in, is leaving the stomach. Okay, we can relax the sphincter because we can allow more food to come in. Makes sense to me. So what I have one of these mismatch questions that you see all the time that are there. Which agent, and it's a bunch of these enzymes, which one is appropriately matched where it's produced. So try to see those answers that are there. So if I'm talking about proteolytic enzymes in the mouth, then you know that that's wrong. Just to give you an idea. Okay. And so there's a variety of things. So that's one of those mismatch questions. And I do a lot of those. The following are true, except what occurs, for instance, in the small bowel. We know it's where the vast majority of the digestion and almost all of the absorption occur. You have to understand what the pH is about. You have to understand what's going on with all of these, whether it's fats, proteins. We don't even touch nucleic acids until they get into the small intestine. That's part of what the pancreas produces, and it breaks it down so we can absorb the components to enable us to make more DNA and RNA. Just makes common sense to me. Review the anatomy. This is when the villi, those interesting fingers, so you have a lacteal surrounded by a capillary bed that's there. And what they do. What's the lacteal composed of? Remember the hallmark epithelium of the stomach? Simple columnar cells with microvilli, creates that brush border that's there, and goblet cells, because the mucus is really important. And remember the circular folds that are there, the plica circularis. So all of those are really important things to recall what's going on with the stomach. And again, review because the anatomy and the physiology are tied. That's where we get that. But I reinforced it a little bit when we were talking about lecture. You have effectively it's the common bile duct, but it's the hepatopancreatic ampulla and sphincter. But the pancreatic duct is coming from the pancreas, and the bile duct, where goes into the hepatic duct, is where they join together and enter the small intestine. Okay. Don't forget the role of a lot of those structures. I emphasized it several times. The role of the appendix, which is that interesting kind of twisted structure that gets clogged with appendicitis, is effectively when we have colitis or some type of significant, diarrheal episodes, and after a really bad bout with the flu or some kind of stomach illness, gastrointestinal illness. Effectively, their job is, we feel now, other than the immunological, is to reseed the area with valuable bacteria. I mean, there's so much today. If you study nutrition, if you study people immunological responses, our normal flora, specifically the gut bacteria, are so important today. They're different in different types of peoples. They study them for diseases. It's a very interesting area of research that's there. So what goes on is effectively, that's a valuable role, but it's more immunological because, again, water, electrolytes, maybe making some vitamins. That's about the size of it. I'm getting there. Just chewing on something to keep my throat moving. Okay. Then that's sort of an overview of what you're going to see. There'll be some more specifics. I would think you're going to have to remember the name of, like, chymotrypsinogen becomes chymotrypsin, that type of stuff. And I'll try to familiarize with the carboxypeptidase and, you know, all of those types of things, where they start pro-carboxypeptidase. It's pretty easy to distinguish what's the inactive form, because we don't want to auto-digest, because they're proteolytic enzymes. They don't care. They'll just digest proteins. That's a big problem when they get out, when they shouldn't. If there's injury, damage, illness, pancreatitis, which typically comes from alcoholism, but it's not the only cause. That's there. And brings us really to start the kidney-based questions. So the renal-based questions start with the kidney. The functional unit, we all should know this. This is anatomical as well as the glomerulus. And as a bigger point is the nephron. It's really divided into the glomerular area and the tubal area. Those are the two areas anatomically. You've got to. This is more anatomy, but it's integral to the physiology. The system only works because it's a high pressure filter. And it's the unusual thing about the blood supplies. You have arterioles running in and arterioles running out, because that pressure is the driving force to create the filtrate. Without that driving force to create the filtrate, energy would have to be expended. And so we wouldn't have an arterial or blood, or oxygenated blood in, oxygenated blood out. It would already start to change into venous blood. And then that blood wouldn't be useful for all of the resorption and secretion, which is all active transport. So that's the first step, where we look at anatomical basis for function, anatomical basis for diseases, and this is all part of it. So as we continue to look at this, I'm going to do a quick check on something. Last time I did something dumb. I was doing a recording for the other class, and I didn't check my settings, and it ended up I had to redictate the whole thing, which is not very much fun, I must tell you. But thankfully, that is not the problem today. I will go back. Give me a minute. Here we go. So remember the anatomy with regard to those things that are there. The role it plays. What is the Bowman's capsule? It collects the filtrate. What comes next? Proximal convoluted tubules, the loops, distal convoluted tubules, collecting ducts. You remember all that type of stuff. The big deal, most of the work gets done in the proximal convoluted tubule. The vast majority of the resorption and the vast majority of the secretion is done there. If anything, the distal convoluted tubule is much more about finalizing and basically making sure the appropriate amount of waste products are put in. Minimal resorption, mostly secretion. But the vast majority of the activity is certainly proximal convoluted tubule. The thin descending loop, all about water. Okay, even if we're dealing with the cortical nephrons, the ones that don't have those long loops, because certainly the vast majority of the way we concentrate our urine is in those juxtamedullary nephrons. So here what occurs, there is going to always be some water that moves it. They're all going to have the same kind of a gradient that we talked about with the countercurrent systems that were there. But in general, the thin descending limb, water, the ascending limb balances it out by basically moving sodium and potassium and chloride about. I mean, so that's pretty consistent to remember about. You know about the juxtaglomerular apparatus, you should be familiar with that. The renin-angiotensin mechanism, you should be familiar with that. All those areas. So remember the anatomical structures, the mesangial cells, the macula densa, the JG cells, etc., and what they do. Most importantly, this massive amount of filtrate, you're basically filtering your blood in a day 30 times. So typically you're creating about 180 liters. You average about 6 liters of blood. of filtrate. We reclaim 99% of it because we basically urinate out between 1.5 to 2 liters a day for most of us, depending on how hydrated or unhydrated or, a number of factors. I'm just an average, of course. So filtration's about the blood pressure. Remember the role of all those things. What angiotensin 2? That's the active form. The 4 different things that angiotensin's name tells you. Angio, blood vessel. Tensin, tension. In other words, make it taut, increase blood pressure. Stimulate your thirst center in the hypothalamus thing. Stimulate the release of that's antidiuretic hormone. Stimulate. So first it increases thirst and then stimulates antidiuretic hormone. Antidiuretic hormone inserts typically into the collecting ducts, different passageways that are going to allow water to be basically be reclaimed and not urinated out. And so basically distal convoluted tubule collecting duct area. And lastly, and most importantly, activates the angiotensin aldosterone mechanism. The angiotensin signals the adrenal cortex to release aldosterone, inserts again those basically protein-based passageways into the distal convoluted tubule, into the collecting duct area, and allows sodium, actively transports sodium out, and water will follow in whatever direction it's going. So it's taking it out of what would be the urine and bringing it back into what's going to be reabsorbed. So it's all about increasing blood pressure, tightening the blood vessels, drink more, and reclaim more fluid. And again, typically when sodium goes out, potassium goes in. That's the thing that you have to be so careful vis-a-vis potassium levels, the role of the sympathetic nervous system with regard to kidney function. There is no parasympathetic innervation, period. Because it's all about the blood vessels, it's all about blood pressure. So all of those types of things that are there. My spelling is horrendous. I should really have rechecked it. So if you'll see some typos on this, I didn't get what I think I said this already. I remember I talked in passing about the countercurrent multiplier system. That's concentrating the urine. The countercurrent exchanger, removing the electrolytes, that's all about maintaining the countercurrent multiplier. Remember those paralleling loops? It's hard for me to explain, so I don't put a ton of questions with regard to that. I think that's wrong, and really understand what's not supposed to be in there. I spent hours of time. This is on diabetes, which you should have figured out is one of the most important areas to know about. Glucose, what shouldn't be in there? White cells, red cells, proteins, glucose. It tells you something. If it's red cells, white cells, proteins, crystals, casts, which are basically proteins, those unusual things you find in the urine tell you that there's a problem with the glomeruli. Stuff's getting out there. There's damage. Or there's something else wrong that's causing significant problems. And based on what it is, you have to investigate. If you see glucose, it means there's too much glucose in the bloodstream, and those transporters for glucose, that's really a secondary actor, transports sodium, and then it co-transports glucose along with it, or symports, whatever term you want to use. Those are occupied and spills into the urine. That's always the term. That's what happens in diabetics, or people who don't know they're diabetics, or people who are becoming diabetics. And the whole idea is to keep that below the transport maximum when you're managing a diabetic, because the longer it's a transport maximum, it continues to damage those transporters, and the maximum decreases, which means your sugar goes up. There's so much to it. I mean, we literally had whole courses dedicated to these kinds of things. If you get into it in graduate and medical, and particularly you're focusing on diabetics, which I happen to do because of all the foot problems they had. I mean, you're spending months going over these types of things because it's such a critical region to understand what's going on. Even though we didn't manage the disease, but we had to treat the damage of the disease. Very significant. So again, all those types of things, and we all talked about cigarette smoking and bladder cancer. If you don't figure there's a bladder cancer question or two on this test, you ain't been listening. understand what the constituents are in urine. It's basically mostly fluid, so it's hypotonic. It's typically slightly acidic. There's a fair amount of dissolved material. That's how we determine. It's called specific gravity. Again, what shouldn't be in there more than anything else? So it's just waste products, a large amount of water, the the remnants of the bilirubin, which by this time have become urobilinogen. Not that you have to know that. There's a reason why it has its specific color. The yellowish color, they're simply associated. More intense if you're dehydrated, paler if you're overly hydrated, I think would be fair. These are some of the questions now as we get into the unit. I think I don't know if there's 65 or 70 questions. I'll know in a second. We start to review some of the anatomy because it's important physiologically in both the male and the female reproductive systems. So, testicular cancer, the association with cryptorchism. Okay, why do the testes descend? These are all repeat questions. I spent time endlessly about the blood testes barrier. Why is that so important? What happens if sperm get out where they should not be, where they're not contained within the tubular system where they're born and eventually ejaculated before coming in contact with elements that would attack them? Okay. Again, the relationship between this unique, real synergistic, dualism to regulate uh, in effectively arousal, which is parasympathetic, and climax, which is sympathetic. Be aware of those things. I think it's really important. What are the factors that control? Again, knowing the difference between FSH, follicle stimulating hormone, which is sperm production, versus luteinizing hormone, which would be testosterone. And the same applies when we get to, I'm going to move because my back hurts in certain positions. We've got to be able to recognize the same that occur in the female, which I was addressing yesterday and will be completing probably Friday, I hope, which is the follicle stimulating hormone stimulating the production of eggs and maturation of eggs, I think would be a better way to express it. And then the estrogen and progesterone. Now we just started to talk about that vis-a-vis the ovarian cycle, and we ended with that getting onto the menstrual cycle tomorrow, you'll recall. But I'll continue with it. Know what their roles, know the role of GnRH, know what the energy source is for sperm, because it's unique. These are things you have to look up. What does seminal fluid do? What does prostatic fluid do? These are repeat questions from advanced anatomy. I know not everybody had this, but talk to somebody, all sit next to somebody who's had it. Or if not, they're in the vicinity. Ask them. The role of nitric oxide. And again, I misspelled that. I put nitrous oxide. I have to go back and look at my. Oh, gosh, Lewis. You're having a day. Okay. And so a lot of these are repeat questions that are there. Basically, what's the difference between estrogen and progesterone and testosterone? What are the similarities to them? What kind of a chemical is GnRH? What kind of a chemical is FSH or LH? They all kind of come back. We didn't get, and there's a pretty good sized segment when we finish female, and that may be Monday. But we may get a little bit of it on this Friday. So Friday would be the 24th and Monday would be the 27th before we do the rest of the presentations on sexually transmitted diseases. Because we're doing female repro, you have to talk about cervical cancer. You have to talk about HPV. We have to go in and review menstruation. That's coming up on Friday. What arteries are involved? Again, it's anatomy in question. The spiral arteries that are so important. They spasm, and then the pressure builds up. I mentioned it yesterday, the role of the axillary tail with regard to the abundance of lymph nodes, what goes on. Okay, why is it so important in breast cancer? Why do we check the axilla? The principal site of activity, again, of estrogen and progesterone, where they work. Okay. So you can begin to look at all of those. And that's things that we're going to go over in a little more detail, and have started with looking at the ovarian cycle, and then subsequently in the menstrual cycle. Short course. Okay, when we get to the menstrual cycle, progesterone is pivotal in that. So its principal effects are mostly on the uterus during that particular point in time. Okay, where estrogen is really throughout, maybe certainly more active in the ovarian cycle, certainly up until the point of ovulation, and generally, but it maintains its activity throughout both of these cycles. Okay, and what happens if they're in the bloodstream? What are they going to suppress? Ovulation. And really, that's kind of the little way, and my understanding is limited about this, how birth controls principally work. But effectively, and we do this a lot biologically and a lot in medicine and therapeutics. Effectively, what you do is you play a metabolic trick on your body. You say, okay, well, we'll keep estrogen levels high, or we'll keep estrogen and progesterone levels in combination high. And basically, it'll tell you're okay, whoop, we don't need to stimulate, we don't need follicle stimulating factor. And say, so FSH, follicle stimulating hormone, won't be produced. That's kind of the way it works. And if you talk about and I don't know how popular they are today, or how, if they've modified them in IUDs, intrauterine devices, they were basically creating an environment that disfavored, that really didn't permit implantation. They were both very, very effective. Interestingly, the most effective way for birth control, that's probably certainly the least problematic for the female, is, as you might guess, is pardon me, vasectomies. And vasectomies can be reversible. I can account for that with my wife's younger two children by her first husband as post vasectomy reversal. I'm so sorry today. I can't talk. So I think that those are all important things to recall, why I'm going into all of these types of things. So this is where, so you have an idea how these things work. And that's, again, the problem with BCP, birth control pills, is there people, I tell all the nursing students, when you do a history, if you're going to do that, in whatever role you're going to be in, when you ask people about medication, very often they forget that, because I'm just taking a pill. That's what they call it, the pill. And, are you on birth control pills? That's an important question. If you have a woman during their childbearing years, it would be really a wise idea if you asked them about that. I just thought that would be, I lost my train of thought because I got to be, would be important, because the problem with birth control pills, and there's a number of them, maybe they've refined them today, potential for blood clots. It can impact, particularly when they're removed, taking them for long periods of time. You often have to take a break. This is what they did in the old days. You had to take a break from them. At that point, the woman became increasingly at risk of pregnancy. Let me keep going. My daughter's texting me. I'll get back to her. Hold on. So I'll get that done. Apologies. Okay. I just want to get back to her and explain this. Is just more stuff that goes on in our lives. Okay. So I think that all of those are important. So because of that, and this is where I'm finally getting to the point, apologize for the delay. At what happens at menopause? Okay. Now we do not endogenously remake. I mean, you can think of what happened at menopause. Now there's a marked reduction in particularly with estrogen, progesterone less so. Again, more of its effects are on the uterus. With regard to estrogen, what happens? It plays such a pivotal role. So things like with predisposition to osteoporosis, it worsens it. We talked about that in bone. Okay. You're not using, we make them from cholesterol, so cholesterol levels increase. Okay. Secondary sexual organs begin to atrophy. Okay, the system just doesn't work the same. I mean, I don't want to go into you know how should I say it? Uh, I didn't want to necessarily go into chapter and verse and the specifics of what goes on, but I mean, it's part of the aging thing, and maybe we'll get a chance to talk about that. Hot flashes, very very common. My wife has got them, and I mean, I'm trying to think. She probably fell into the average time. I mean, we met when she was 47, so X amount of time after that, 5 7 years, I guess. So I think they pretty well subsided now. My wife's 68, and they can be problematic. And a lot of people, we fight over the temperature. Trust me. So again, I went into these yesterday. What is the mature follicle called? Okay, and oh, I forgot to tell you. And I'll even note it. I will mention that tomorrow and put it in. The old term that we used to use for that follicle that is called a graphian. I don't know where it got its proper name. Capital GRAAFIAN follicle. That's that follicle that has the fluid in it. So it has the antral follicle now. That's the sort of the tertiary follicle, the mature follicle, ANTRAL, or graphian follicle. And I'll make that correction on the test. That's going to be a gimme point. Anyway, and again, you have to know what part of the cycle is what. Don't get confused. The question is it ovarian cycle or menstrual cycle? They have different names. And they both have two phases, the initial phase and the second phase. And again, the menstrual cycle is what starts with menstruation. Then you have basically the developmental phase and the implant. I'll give you the proper terminology when we get to it. And then we went over the ovarian cycle anyway. And obviously, it's separated by the process of ovulation. And again, ovulation is all about the luteal surge, a surge in LH. This is again, we get these interesting positive feedback loops that occur and are very difficult to explain, much more other than the typical ones we teach about blood clotting and oxytocin production and passage through the birth canal as being positive feedback. Female repro's got a lot of that. Okay. Fertilization, we all know it occurs in the uterus. For a big part, implantation in the uterus, fertilization in the tubes. And that's occasionally with tubal pregnancies but that's where they're fertilized. What does the corpus luteum do? You need to be familiar with all of that. Basically, what it does, it takes over the role, okay, of what eventually will be with regard to the uterus and maturing the baby. So what they have a lot of is estrogen and progesterone. That's really the estrogen and progesterone production come in for the first 3 months of that first trimester, assuming that there's been implant fertilization with implantation. A little placenta develops and the placenta takes over. So what's the luteum? What's the corpus albicans? What's left of it? Again, I'm going to be doing a bit about sexually transmitted diseases, just a little, the quickie stuff about that. I mean, and I put that in there for a reason because one, it's in the chapter. I think that's important. And two, I mean, I think it's really important to know about because, the vast majority of the students that I encounter here, they're in the process mostly of starting. They're going to be starting their family soon. Some have already started. So remember the role, for instance, HPV and cervical cancer. We'll discuss that. I'm sure you've heard it more than once. But believe me, you cannot hurt to hear it again. With regard to sexually transmitted diseases, we're going to talk about chlamydia, which is bacterial and it's the most common of them, then gonorrhea, then trichomonas vaginalis. They're all in a certain category called discharge diseases. I have a lot of information to share with you about that because I'm doing it now with my micro class. Okay. Again, we're going to look at, just to review, what hormones are more active in what phases. And again, the distinction between the menstrual cycle and the uterine cycle. So other ones that we're going to talk about in passing, there'll be questions on are gonorrhea, understanding the peak years in men. When do they start? When do we start to produce testosterone? When do men start to do that? At puberty. When does it peak? How long does it peak for? Roughly the the 40-year span in women. Where they're child, what we call the childbearing years. Frequency of breast cancer. That's a repeat question. Trying to think about that. Oh yeah, I remember the anatomy. When the egg is ovulated out, it doesn't go directly into the tube. It's all those mucus eddies and currents that carry the tube by the fimbriae, those finger-like projections in the cilia that sweep it in. So it's remember that I made a big point about that umpteen times that are there. And then the other end. So here are the enzymes to be familiar with: chymotrypsin from chymotrypsinogen, carboxypeptidase. And these are all proteolytic from beg your pardon, procarboxypeptidases. Again, where the location of the counter current multiplier and the exchanger are. So I think you should be that. The approximate transport maximum is about 180 milligrams for glucose. I think that's important as well. Okay, I think that covers everything. So make sure you listen to the to the other dictations if you're unable to be there for some reason in class, and make sure you listen in class. And hopefully you'll show up, unlike yesterday. And I suspect tomorrow's not going to be a heck of a lot better. Just saying. Nice chatting. Saying bye.